I would like to invite Dr. Bhupesh Magga. He's our senior cornea surgeon from LB Prasad Eye Institute, and he also heads the Ramoji Institute of Infectious Diseases and has been working on some cutting edge work in HSV keratitis. Would like to invite him to give his insights on the same.
Thank you. Thank you, IOS, for this opportunity, and Dr. Somshila and Kavya and Vineet for great coordination. So I'm going to discuss in coming 10 to 12 minutes about HSV keratitis. So herpes simplex virus, as we know, that is comprised of double standard DNA and is having a tegument made of proteins and envelope made of glycoproteins. In an updated classification, herpes virus comes under alpha herpes viridae, which has basically few genera like simplex virus and varicella virus. And in simplex, HSV1 and HSV2 are the viruses which I'm going to discuss in clinical implications here. But otherwise, for ophthalmological point of view, all the viruses which are highlighted here can cause sort of virus keratitis. Herpes simplex virus, if you think about that this is not very common, so think about this epidemiology which is from Western countries, that remains a leading cause of infectious cause of blindness worldwide. But there is 1 to 1.5 million new and 9 million recurrent cases every year, which is causing 40,000 new cases of severe visual ocular morbidity. And in more or less, which is very important in per se and which is differentiating from other causes of infections from herpes, is primary and recurrent form because of its predilection for trigeminal ganglion and cause of mode of transmission from anterograde as well as retrograde. This is data from LVP, which paper is under review. From 12 to 2020, we saw around 8,308 patients, and in that, basically there are subgroups which are going to be analyzed. But in that, you can see 92.91% is the urinary environment. In our series, the most common is stromal keratitis followed by epithelial keratitis, which is little contrary as compared to the published series. But overall, this is maybe the pattern of herpes keratitis which we see here, because many of the epithelial keratitis are self-resolving. Diagnosis is mainly clinical, but still we need some investigations in cases which are doubtful or in terms of corneal scraping or anterior chamber tap. So there are 3 investigations which are going to be useful in terms of PCR, GIMSA staining, and IFA in terms of indirect form of immunofluorescence. As you can see here, multinucleate giant cells in the GIMSA, which is basically making the diagnosis susceptible, and also the IFA and PCR, but none of them is single-handedly used to make diagnosis. So the combination PCR and IFA holds maximum sensitivity and gives better as compared to IFA and GIMSA and PCR and GIMSA. So if it is available in your nearby lab and you are having a doubtful case, which case is like almost negative in all microbiology, is always better to do corneal scraping or send for PCR and send for GIMSA or IFA and combine it to confirm the diagnosis. You can also made by cell line culture. Like here you can see the spindle-shaped cells, like these are the human corneal epithelial cells, which is on infection. You can see the cells become rounding and the space between them is increasing. So that's how it, and also you can make it like immunofluorescence on these infected cells. So what are the issues with the HSV keratitis? The evidence versus eminence versus translational conflicts because of lack of real incidence from developing countries, poor or not commonly available diagnostic indicators. Clinical classification is not very well defined, which is layer from years we are using that classification. HEADS trial has been done to rule out for most common type of piece, but not including all the clinical variations. There are high recurrences with lack of data about that, and agreement of treatment across cornea specialists. So what is the clinical manifestations of HSV? Historically, we are basically managing like dendritic, geographical, immune stromal, interstitial, pneumolar. These are the terms which are being used in clinic. But the classification which I prefer and which is like which always good and very simple is based upon the anatomical environment, like epithelial, stromal without ulceration, stromal with ulceration, and endothelial environment, which is always, which gives me little easier and also understandable because the way it is being managed is based upon this involvement. So I'm going to some cases. This is a 25-year-old female with a history of pain, foreign body sensation from 2 weeks using moxifloxacin eye drop 6 times a day. And if you see closely on the epithelium, you can see some sort of dendritic lesions with, if you stain it, it becomes very obvious. So it's very important to stain this type of ulcer or this type of lesion. You see there's a positivity from rose bengal as well as fluorescent. So that's the base is by fluorescent and boundary is by epithelial. And on 2 weeks of follow-up, this is almost disappearance with little bit of subepithelial haze. So treatment is well defined for this type of lesion. Topical antivirals in types of vidarabine, trifluridine, acyclovir. But in our scenario, we are commercially available acyclovir ointment and acyclovir ointment for 2 to 3 weeks, 3 weeks minimum if we recommend it. But the most important thing is no steroids because this is a contraindicated. Manual debridement has some role, topical interferon also some role, but they are not completely able to eradicate, so you need antiviral for this with proven effect. Like this case of keratitis presented to us, yeah. So this is basically, we can see there is a geographical lesion with previous vascularized scar, and based upon that antivirals were started, but topical corticosteroids were also added, and this land up into a sort of necrotizing stromal keratitis. So this is one always lesson to everybody that if you are dealing with geographical ulcer or dendritic ulcer, recommend not to use corticosteroids because then the cornea can behave like that. And fortunately for this patient, we could save the eye by doing a patch graft and later on then keratoplasty. So this is another which is most common way in our series, stromal keratitis without ulceration. So this is the typical scenario. This is a history of blurred vision with white opacity in the right eye. Patient complains of like that with no pain, redness, no photophobia or minimal photophobia, no epithelial defects, stromal edema is present, but no KPs and no AC reaction. So this is how it presents. OCT, you can see the corneal thickness is increasing with typical loss of the concavity of the cornea from behind. So that's how it presents, and that is basically make it different from other modality where the corneal edema presents. And this is the treatment is topical corticosteroids with gradual tapering, and you can see the response in 3 weeks is dramatic response with oral acyclovir should be given in prophylactic dose to avoid epithelial recurrence. This is the second variety with the stromal keratitis with ulceration, where the presence is like this. Difficult to differentiate from other causes of microbial keratitis. So definitely you should rule out by corneal scooping and as Dr. Nikhil described about the microbiological workup. And this patient was having a recurrent history. You can see you should look for other telltale signs of herpes viral keratitis like vascularization or iris atrophy. Like this guy was having iris atrophy, central focal stromal infiltrate with overlying epithelial defect and sectoral iris atrophy. So this we suspected, and we did IFA and PCR also came out to be positive. We started oral acyclovir and then later on added topical steroids and resolved in 2 weeks' time. Here you can see better iris atrophy patch. So this was the way it is being managed as NSK or necrotizing stromal keratitis when the history of recurrence, wide granular interior to mid stroma infiltrates, overlying epithelial defect, presence of ghost scars, neurotrophic cornea, vascularization. Other microbiological workup is negative. Try to fix it with IFA and PCR. Even if it's not, try oral dose of acyclovir and assess the response and then add topical corticosteroids. Other modality which is not covered by heads is endotheliatis, like a history of 40, this is a 40-year-old male with recurrent episodes of pain and redness. As compared to immune stromal, patient will have severe photophobia, and TH chamber inflammation is minimal as compared to other types of uveitis, where you see multiple white capes, and which is very characteristic, this is underlying the area of edema. So you won't see beyond the area of edema, and that's the way endotheliitis presents. You can see in the OCT as well as those big KPs, and this is the type of you can say sectoral or disciform endotheliitis. The other form is diffuse endotheliitis, which is a type of diffuse corneal edema, and often being diagnosed as toxic keratitis or corneal endothelial dystrophy, and many a time this being diagnosed as corneal edema. If at all patient is having pseudophakic also, and advice for going for some sort of endothelial keratoplasty, but we need to look for the history and careful documentation of fine KPs behind those endothelium, and this patient respond usually with topical corticosteroid. We need intensive dose, not 4 times or 6 times. We need at least 2 hourly dose of intensive topical corticosteroids with full oral antivirals 5 times a day for at least 3 to 4 weeks. This is not very common to see, but often misdiagnosed. HSV sclerokeratitis. Like this patient was having history of off and on redness and pain from past 2 to 3 years with no history of systemic disease, and very importantly, this is having posterior stromal cellularity, not the anterior stromal, with no obvious epithelial lesions, and they respond beautifully with topical and oral corticosteroids, and you see classical crystalline deposits in the posterior stroma if they resolve. If you see this type of posterior stromal crystalline deposits, always make a red flag sign this patient might be having some form of sclerokeratitis, and do not operate without under cover of anticyclovir. So this patient of having graft for corneal scar, in 1.5 years, he came with photophobia, and when we got it, dendritic lesions on the graft host junction. This is the typical recurrence of herpes on the graft, which responds with nicely if you stop steroids and add topical and oral oral antivirals. And this is another variety of epithelial keratitis, which is marginal keratitis, and this is the only type of marginal or epithelial keratitis where topical corticosteroids has been indicated, and the response is many times good. And this is another way where the chronic herpes keratitis with the deep vessels, lesion of deep vessels presents, and you see if there usually comes with a quiescent eye with mild ongoing inflammation, like in terms of stromal edema and little bit cellularity and lipid keratopathy. So treatment is continuation of antivirals with the low dose of corticosteroids, but later on you can do fine needle diathermy of these vessels, and the response is sometimes so gratifying that you don't need any transplantation, particularly for these type of cornea. This is not always so simple. Sometimes appearances are deceptive. Like this guy was presented to us like a white capes and stromal edema. We suspected in terms of fungal endotheliitis or fungal posterior stromal lesions. We did endoscoping and intracameral voriconazole. But there was no organisms on follow-up, so we started thinking in line of viral. We did do at the time EC-TEF for ruling out viral keratitis, but we started separate trial of antivirals and assessed the response. The response was quite gratifying when we added steroids, and it actually responded so nicely. The same time, similar time, 1 week later, this patient came and came like this, also came out to be negative on microbiologically, and so we started again oral cyclovir and steroid. This patient also responded nicely, but after 2 weeks, this patient came with the worsening of infiltrate, and it came out to be fungus. So the lesson learned is we need to rule out it, but keep the patient under close follow-up. And when you see this carpet-like capes as compared to endotheliitis, think about viral etiology as compared to this type of bunch of exudates along with like capes looking like capes on desmet. Can it be a fungus, and need to rule out and keep the patient under very, very close follow-up. Fortunately, this patient managed nicely with the help of keratoplasty. So thanks for the opportunity. I would end with my talk with this.
That was again a wonderful presentation, sir.